have a quick poll, and the purpose of the poll is just to have a feel of where we are at. So we're going to have that poll launched, and I encourage everybody, please let's get on and let's participate, okay? So we can get this moving and get right to discussing. So let's see. Number one question here says, who do you think plays the biggest role in maintaining your health? Is it yourself? Is it your doctor? Is it your family or support system? Is it the healthcare society? There's all that. All right,
The
let's see.
panelists, should we participate since we obviously have an idea what the answers should be?
That's a very good question. I think it would be nice to
Okay.
maybe you should participate. You can encourage other people.
All right, then we will.
Thank you, ma'am. Thank you. Okay, let's see. And the second question, when you hear proactive care, what comes to mind first? Regular doctor's visits, healthy eating and exercising, early testing and monitoring, mental health and stress management. What comes to your mind? Then number 3 says, how often do you schedule routine health checkups or screenings? Regularly, occasionally, rarely or never? I'm not sure what I should be checking, okay? Then number 4 says, what's your biggest challenge when it comes to taking preventive action? Cost or access to care, lack of time, not knowing what to do, fear of results. Yeah, that number 4 is a big one. And then the very last question we have here, if you could improve one aspect of your proactive care routine, what would it be? Tracking my wellness numbers, staying consistent with exercise, eating better, managing stress, scheduling regular checkups. For those who are just joining, let's see, it would be nice to have you join in this poll. There's 15 of us and only 9 of us are responding. We have about 1 more minute. So if you're yet to respond, you still have about 40 seconds and then we will shut down the poll. Okay, let's see. Thank you. 11 people now. That's good. Okay, so we have 11 of us, and then we are going to stop the poll now. And you should have the results on your screen. Can someone confirm that you have the results? Yes, okay, thank you. So who do you think plays the biggest role in maintaining your health? I see here the majority says myself, okay? And one person says my doctor. Okay. All right, let's see. Second question. When you hear proactive care, what comes to mind first? And majority of us say healthy eating and exercise. And then there's also early testing and monitoring, okay? I guess we know what our first question is going to be for today then. Then number 3 question says, how often should you schedule routine health checkups or screenings? And we have majority saying regularly, at least once a year. We also have occasionally, that's one person. One person says rarely or never. I hope that we can address that by the end of today's gathering event here. Number 4 question says, what's your biggest challenge when it comes to taking preventive action? Cost or access to care, 2 people. 7 people said lack of time. And I guess that's being real. Okay, luckily it's not fear of the results. Number 5 is, if you could improve one aspect of your proactive care routine, what would it be? And 4 of us said it's going to be staying consistent with exercise. 3 people say it's going to be managing stress. 1 person says it's eating better, and another 1 person also says it is scheduling regular checkups. I think all of that is beautiful, and at least to our panelists, it helps you to feel the pulse of the room to know what people might be itching to hear today. All right. Before we finally get into the discussion, there are some things that it's important that we know. And just because we like to ensure that our program keeps up with public health trends, and if you've been here before, you would hear me say that we like to ensure that whatever topics we are talking about, they align with the SDGs as provided by the United Nations. So I'm going to quickly share my screen. And this SDG that we're covering today is number 3, which is good health. So we are talking about proactive care. And of course, it all matters the kind of health experiences that we have. So that's what we are covering today. And this is important because our health, everything factors into the well-being that we enjoy or that we do not in the long run. And then the next thing we'll be having is also a definition of terms that we should understand. Well, I'm going to skip over these just because they weren't updated, and then we will go to some did you knows, so some facts that we should know when it comes to our. Let me share it again. I believe something is going on with my device today. Okay. All right. Yes, now you can see the did you know screen. Okay, thank you for letting me know. All right, so number one fact here is the amount of money that is being spent in on proactive care. Investments in proactive care could reduce US medical and prescription drug spending by 28%. So we already know that the healthcare industry is a very expensive industry. However, not just my opinion, but we also statistics shows that if we actually if we attack or if we approach our healthcare management from a preventive standpoint, we also get to enjoy lesser health costs. And hopefully we can get to talk about how that might be, but that's a fact that I thought was very interesting that we all need to bear in mind. We also see here, like point number 3 says that it is estimated that up to 80% of heart disease, stroke, and type 2 diabetes, and over 1/3 of cancers could be prevented through healthy diet, physical activity, and avoiding tobacco use. And how would people know to avoid these things except they are taught these things and then they practice them. So with proactive care, it's knowing what to do. And people only get to know what to do if they are taught the things to do. So that's an interesting fact there. Another thing, let's see. Number 5 says preventive care services are most effective when timely. And delaying or skipping them means missing opportunities to catch issues early when treatment is easier and less costly. When I was finishing my MPH program, um, what's the thing now that we did? My presentation was about non-communicable diseases and how we need to encourage the need for preventive actions like screenings. Because many of these things, if we tested right and we applied timely intervention, they can actually catch a lot of things that if we leave them without attending to them over time, then they now degenerate into, graver issues. But timely intervention goes a long way. And that's one of the main tenets of proactive care, just being able to get in there before things start to go worse or terrible. So if we can run through the list here, but I'm just going to share with you why talking about proactive care is important. This is not just something we are doing because it feels nice, but it's something that I believe we should know. And that said, we are now going to start asking questions. And I believe our doctors are ready to take us on. And in no particular order, to Doctors Fee and Dr. Joy, we can just pull out the question there and you can come at it as you want. So you can, in some cases, I would call on a particular person, and in other cases, you just jump in as you feel led to respond. And there are other people, to the rest of us here, please type in your questions so that we can also capture the thoughts that you have in your mind. So to start us off, the very first question that I would have to both doctors is, how would you define proactive care in your area of specialization? So let's start with Dr. Fee, just because.
Proactive care in my field. So I am primarily primary care physician. So that entails yearly physicals for men, women, and children. That entails getting screening exams before you have symptoms. So there are specific screening exams for men, for women, for all adults, for all children. And then it also entails getting your vaccines. So I would say those are the main tenets of proactive care and primary care: physical, yearly physicals, screening exams, and then vaccines.
Thank you, Dr. Fee. Dr. Joy.
Forgive my ignorance with operating electronics. I was clicking the wrong button. So in my field, obstetrics and gynecology will be maintaining regular screening, like Dr. Fee already mentioned. Um, as recently, obstetrics and gynecology is considered part of primary care, so cervical cancer screening comes to mind. A lot of young people or women do not think it's necessary to get their cervical cancer screening because they deem themselves not at risk, unfortunately. Screening mammograms for women begin at age 40 or 10 years sooner with a family history of breast cancer, colon cancer screening. So some of our screening do overlap with that of the family medicine docs because majority of the time, if they have a primary care doctor, by the time they come to me, they've already checked off on their screening. If they're planning on getting pregnant, a lot of young people who are planning on getting pregnant do not realize that what we call preconception counseling, it is actually part of being proactive. Um, I always use the analogy to my patients that if you're a gardener and I'm not, so this is not because I garden, you till the soil, you put fertilizer, you prime the land, so that by the time the seed drops, you're going to get bountiful harvest. Likewise, in pregnancy, we know that a healthy body, a healthy mind, a healthy environment promotes good pregnancy outcome, and hence, we can reduce the risk of, birth defects. If they're taking their vitamins and folic acid, a lot of them don't know that taking additional folic acid before they plan to get pregnant 6 months ahead of time could reduce things such as, birth defects and even neurocognitive disorders, because we know that folic acid is part of our DNA, and also reduces hyperemesis gravidarum, which we know the metabolic imbalances that come from that can lead to neurocognitive disorder for those babies. So that we see that as part of proactive care. And my colleague Dr. Fee already elaborated on how both for men and women. I do not see men, but often when they come with their wives or their partners, what can I do? We're contemplating having a family. I always tell them, if you're not healthy, get healthy because that could affect your sperm count. And of course, a healthy father presence in conceiving the baby is also needed, to care for that baby in the long run. So, generally being active in taking steps to care for themselves, in my field.
Thank you. Thank you so much. Very well said. And I go back to the poll questions that we had, and there was the question about how often, or what should be the approach to proactive care. And I believe one of the responses was rarely or never, or it should be at least once a year that you should schedule routine checkups. For people, and this is, we can assume that those of us here, maybe a large portion of people here, probably know what to do. But that does not take away from the fact that many people are still ignorant to how much intentionality goes into managing their health. So the question that crosses my mind then is, why do you think people wait for symptoms before they seek medical attention? And any of you doctors can jump in.
Oh, looks like I never muted myself back. So I'll jump in.
Mhm.
I think the biggest reason is people just don't think it's ever going to happen to them, you know, or you've been healthy all your life. Have a lot of people who tell me, you know, when encouraging them to get the flu shot, they're like, well, I've never had the flu shot and I've never had the flu. Um, People who come in with colon cancer, I haven't seen the doctor in 20, 30 years. So of course they didn't get, you know, their colonoscopy when it was time. So, you know, that thought of, well, it's never going to happen to me. I don't have any symptoms, so why do I need to get checked? Definitely is the number one thing. And then I think also, especially for younger adults, maybe 20s, early 30s, you know, lack of time, just busy with the kids. So they're taking their kids to their appointments. I think a lot of parents do well with that also because school requires different things, but they just don't have time to do it for themselves. And then thirdly, a lot of the places I've worked, money is a factor because even though the visit might be covered, especially if they're Medi-Cal or well, Medi-Cal is in California, Medicaid. You know, the visit is covered, but then all the things that you're ordering for them are not, you know, they still have to pay something out of pocket. So then we may see them for that physical, but then they don't follow up. And so that's, you know, finances. So.
Mhm. Thank you. Thank you for sharing. Dr. Joy, do you have something to add to that, or would you want me to rephrase the question in another way?
I wouldn't add much because she covered most of it is they don't think it's going to happen to me. It's going to happen to the other person.
Mm,
Finances is a big drawback. Lack of time for several reasons. They're caring for a young family, like she stated, or in some of my patients, it's they are taking care of their aged parents, or they're the center of the sphere for everybody else in the family, cousins, uncles, and aunts, and they delay their own care. Um, and just the thought that I'm healthy, they deem themselves healthy and never know what their numbers are till they have first chest pain or stroke, and then they realize I was actually in trouble. Yeah.
mm. Dr. Joy, when you were talking initially, especially with being a gynecologist, and you had mentioned in instances when you have husbands bringing their wives, and I'm thinking, even just from a personal experience, I've had instances when I go to the doctor and then I want my husband to come in with me because I'm like, number one, I can't regurgitate what the doctor is saying, so just come and hear for yourself. But have there been do we think that having spouses come to visit together, this is not, of course, always applicable, but is there a way, or is it possible that if spouses come for visits together, it might increase the chance of having them follow up with, maintaining their health more in terms of proactive, visits?
Absolutely. I always commend the husbands who brave come in, with their wives for the annual exam, or, they just have a test result and they're like, I brought my husband because when your office said come in to review this result.
Mm,
Second pair of ears is always important because often when I have to deliver a sad diagnosis, that patient is in shock. It's almost like she's in a movie where you're hearing that ominous music playing and they don't hear anything else. And the spouse is the one who listens or, family member they bring. But I think bringing the spouse and most men tend to be more objective, in terms of their problem solvers by nature. The doctor says you have this, let's go. The patient hears you have this. Are you sure? Did you check first? Is this happened to anybody else? There's that denial and the shock. Um, I like when the husbands come with the patients. For my preconception counseling, I get more success rate in terms of, okay, your weight is a little bit on the heavy side. The patient gets upset when you mention weight, but the husband says, she was looking at it from, obesity can cause XYZ, but if you lose 5 to 10% of your body weight, we can get better outcome. And also, when I tell the guy, it looks like from your history you've had, problem that could lead to low semen count. You need to do X, Y, Z. I would tell you this, the guys are more proactive. Let's get this test done. The ladies are dragging their legs to get the HSG, coming for your AMH or your FSH levels, which is a hormonal assessment to determine, what we call fecundity rate, the success rate to get pregnant. The guys are on it. Before you know it, I have the semen analysis result because they want to go. And that's just the nature of a man. I think it's better and it can lead to better proactive care because men by nature are problem solvers. They just want to get going and let's get this thing done with.
Thank you, Dr. Joy. And not to rout out the man of this house, but I'm actually the one that schedules the annual physical. And so I'll bring it to Dr. Faye. What do you think in terms of spouses being accountability partners for each other and ensuring that each person gets the care that they need for themselves? And, touching also on the fact that you said in most cases they are taking care of the children or we are taking care of parents and other family members. So how can we lean in on our community for that accountability support that we need?
I mean, Dr. Joy said it all as far as whether it's spouse or sibling or whoever, the more the merrier for me. It's just a lot easier when there's other people there.
Okay.
Welcome, welcome, TJ.
Hi,
That's a,
TJ.
that's a, that's our future panelist right there, your future
Yes,
doctor right there.
amen. Amen. All right, thank you. I'm not sure if you're, okay, I guess you're done on that thought. Okay, so while we help Dr. TJ get settled in, we'll continue with our questions to come finishing the thought of, I am fine. What then can we do, Dr. Joy, to help people to know I am fine doesn't cut it? What then can we do to help people to, move it to actually coming into the doctor's office from I'm fine to being in front of the doctor? What must be done?
First of all, I want to commend you for this platform. This is the first step. Um, the reality is that most people in their daily lives um, hide under that I am fine. And how to crack that shell that you're not fine and come out is something I think, we're still going to be dialoguing for many, months or centuries, who knows, if Jesus doesn't come. But forums like this could be places where people could take away information and say, hey, this is what I learned. This is important. You're not really fine. And it is possible that they are fine. Majority of the time, when we're eating right, exercising right, we're not balancing stress very well. We're not sleeping well. And the reality is that if you do not actually, maintain all those principles of health in a way that is, I don't know if we can do 100%, but at least approaching close to 100%. There could be little, defects in the chain per se that needs to be assessed. The person who is eating right, exercising, but doesn't sleep well, gets emotional stress, could have anxiety problems. And that
Mhm,
anxiety, if not checked, will eventually lead to hypertension,
mhm,
tachycardia, or cardiac symptoms, that they could perceive. I think I'm having a heart attack, but it may just be chest pain due to their overly anxious. And so visiting a doctor and hearing that, okay, if you're not sleeping up to 8 hours a day, ideally we'll want to strive for 7 hours or more, but 8 hours is perfect if you can get it. It could trigger symptoms that could affect you. We now know that chronic sleep deprivation could lead to dementias and worse than Alzheimer's and could eventually cause other health issues. Um, I never want to take away from a patient that you are fine. It's empowering them that you're fine, but we could do better. For me, I find that when you empower a patient to acknowledge where they're coming from, they actually trust you more to say, I'm going to come back and hear more what you're saying because you didn't knock them off their pedestal and tell them they're the worst in what they're doing, but you encourage them to say, take baby steps from where they are. Um, your forum, and this is the first time I'm hearing about it, but I wish there are more of this and the conversation is happening worldwide. And I think, just like a ripple, one pebble, the ripple effect will spread.
Amen. Thank you. Thank you for the encouragement, and I thank everybody here for the support. It takes a community to ensure that we are collectively well. So that's what we're doing, and we hope that we can save a life and save a couple more. I do like what you said about you're fine, but we can make it better. I think that's something that we could actually, we could just end the event here. You're fine, but we could do better. If we all came, if we all had that mindset, I believe it would help us, it will move the needle, in the right direction. But we're not done. We have a couple more questions that I believe will be lovely to address. And the next question that I have is, and again, please, I see that the fowlers have entered a question. Thank you for that question. Every other person, please, if you have a thought or you have something that crosses your mind, please put that in the chat box also so we can read it out or we can ask the question. If you want to ask your question in person, you can just signify and then we call you to speak. But as we continue, there is some people have reservations about going to the doctor, either because of an experience that they've had before, or either personally or, through third party means. How can we address the reservations that people have about healthcare professionals? It might be the doctors or even just regular nurses or even the medical assistants at the desk. But how can we address reservations being a hindrance to proactive care? Dr. Finyu, you want to take that?
Sure. That's a tough one because the fears are real. People have had unfortunate experiences at the hands of different healthcare professionals, unfortunately. So, the best advice I can give is just to, at the end of the day, no one is going to care more about your health than you are. And you can't put your health in someone else's hands. So if you had an unfortunate experience, um, I would say find someone else and keep shopping around until you're comfortable. Try to get personal referrals, one-on-one, referrals. That usually is better than kind of just shopping around based on the people that your insurance gives you. So if you can find a personal referral, that'd be good. For Black people specifically, there are so many sites I can put them in the chat, but where you can find Black um, physicians and other providers. There's networks where we enter. And so if within your insurance or within your local community, you can just look for that. Most of the time that will be, a better experience overall. Um, what else can I say? But the most important thing is not to give up based on one or two bad experiences, but definitely go where you're heard. And don't be afraid to shop around until you feel comfortable with who's taking care of you.
Thank you. Very well said. Any input? Anybody else has something to add? Dr. Joy, anybody? If not, we can, okay.
I was going to add that unfortunately, I see us as medical personnel as gatekeepers. The patient is in charge of their health. I always inform my patients that primarily you are the main, controller. You're inviting me to come on board, to be a participant in your health, but you drive it. But now imagine this person that is in charge of their health. They show up to the gate and you slam the gate on them, or the gatekeeper abuses them, and you want them to keep coming back. Dr. Finney aptly stated it. The fear is real. Many of them have gone through such horrendous stories. We don't have enough time for me to go through what some of my patients go through, and then they get to me and they almost see like, wow. And I always remind them, I said, no, it's not because I'm unique or special. This is what we're supposed to do. That first doctor was supposed to take the time to hear you out. Being heard is very essential. And being the gatekeeper, if we're not full of compassion, understanding and showing empathy, you're going to ruin or run them away. And the fear to come back again is like they've already been hurt once. Why do I go back? Even with the websites, it's amazing. We have tons of resources there, but they are afraid to go back. And when we see data I don't know if any of you is familiar with the data that was published that, maternal mortality is highest in the hands of, non-ethnic doctors per se, or, the pediatric children are less likely to die in the hands of an ethnic person or a Black person. I'm not surprised because, it's there. You see it. As an obstetrician, I take my own L&D unit. I'll walk into L&D and a patient is in pain. I'm contracting and hurting. Oh, she's just dramatic because of the color of her skin. She's full of drama. And of course, they know not to say that to me because they've had their behinds hung up on the ceiling several times. So when I walk on the floor, why is this patient hurting? Either she declined epidural or there's a contraindication, to her getting epidural. Or pain medication, did you ask her, what is she's not allergic to so we can give it to her? The reality is that, some people are looked upon as it's okay for you to suffer, or you don't. Your blood pressure is because you're high strung, you're stressed. And when in reality, they have preeclampsia. It's sad when I have to review cases on, blood pressure that was not as a peer reviewer, you get to review some disturbing chats, from your colleagues. You wonder why was this not addressed? Oh, well, she's always dramatic and always high strung, and you think this blood pressure is normal. And when you lose a baby, you realize it wasn't high strung. This baby was crying out for help. This mother was sick. But those are the real fears. So I tell patients if you go in on that initial rapport, it doesn't have to even be a complete visit. That initial rapport, the physician doesn't seem interested and is already prejudiced towards you. There's something called implicit bias. It's a test that I recommend for all the students I teach. I tell them go take that test. For me, when I took that test, I was surprised at my own, implicit bias that I was a bias towards, people who have a bigger BMI. And I asked the Lord to help me to see them for who they are because they do have, challenges that led them to being obese or challenges that keep them from, losing weight. But a lot of us have that. And of course, the lighter skinned people have their, bias for several reasons, which I can get into their head and understand it. But they sometimes they see people that are not their ideal color as, they can have pain, their blood pressure can be high. But I'm not saying that all of them are that way. There are excellent physicians that are of a different skin color that really listen and hone in and care for their patients. So because of that, patients run away. It's now how we can now open the gate and say, you're safe here. You're welcome here. You can come in here. I think they'll come back. But, be diligent about who you're talking to and how you find your doctor. Don't just go by what your insurance referred to, which is how some patients find their doctor. Go by word of mouth.
Thank you. Thank you so very much. And I do acknowledge your hand for the panelists. But before you come on, I do want to share a personal experience. A couple of weeks ago, I was supposed to get an imaging done. So I went into the office and the lady because they see your file. So the lady at the desk, she saw my primary care physician's name and said, "Oh, she's your doctor too." And she went, "Oh, she's so lovely." And in my mind, I'm like, I am still trying to, understand, where I am with this doctor. And I share that too. And she's lovely. It's just, the circumstances that have brought us together are a little interesting. And I share that to, touch on the fact that, in fact, somebody, just like Dr. Joya said, not because your insurance recommended that person, you need to know the doctor for yourself and make sure you are a good fit, also completing, following the thought that Dr. Fee had shared. Sometimes we go to certain doctors because they've been recommended. Oh, my aunt, she was so good to my aunt. She'll be the best doctor for you. And you get there, you find out, this doctor is not exactly who I need. In such cases, do not stay out of obligation because, the person was recommended or, yes, you might give some time to see if you have a good chemistry, but if the doctor is not servicing the need that you have, then I think, we can agree that as has been said, just keep moving, keep searching until you find that care provider who gives the care that you wish and you look forward to. May I have Dr. and Mrs. Fawale?
Thank you. Thank you very much for the subject matter today, and I appreciate our panelists for letting us know that this is reality. And I just sometimes it's not that straightforward in terms of the luxury that you have in just going about on second, third kind of opinions. It is not that, the market, doctors are even fewer than they used to be because so many doctors are really not even getting into the clinical practice. So in a situation where you don't have the luxury of just going all over the place to look for doctors, I think we should continue to give our doctors the benefit of the doubt. Whatever the skin color they are, what you want to do initially, you want to actually find out the kind of practice style of your healthcare worker. You will find out even in interacting with them. You can also ask them questions, but because we are not trained as people that are being served to be open and ask our doctors. Quite a number of people look at doctors so high up. Yes, they may be high up like that, and you think that you might not even communicate with them. But this is your health. You are being proactive about it. That's why we're talking about this. It is your health. And uh, you know, the doctors, the nurses, and all the healthcare workers that we go to see, they are like every one of us. They fall sick too. And sometimes I see how some people hold us as if we are so infallible, as if we are so much up there. And that is one of the reasons that I went into healthcare and I did the whole gamut of it so that I'm able to talk to people and to address them so that they don't take doctors as little gods, but as people who are there. You want to make sure that your doctor, your healthcare workers have you in mind. They have a practice that is patient oriented because you don't know what is motivating people to go into their professions. In the profession that I am in medical dental profession, majority of the people that are there go in there for the money. Unfortunately, there is the money that used to be there is no longer there, but you will know right immediately when you go into their office, the time they give for you, whether they are rushing you in and out. And then you can go and look for someone else like our panelists have talked about. But in looking for someone else, you might not be able, you don't have that luxury. But in the case where you don't have that luxury, uh, just know that it is your health, and you also want to know your numbers, basic information. Just insist that you get those information, and you might also be helping your doctors, your healthcare workers in the way they take care of you. When they know that you are very active in your own care, the doctors become active as long with you. Thank you.
Thank you so much, sir. Thank you. It's really lovely to hear your perspective. I think I believe it's important to touch on the fact that yes, it's not everybody is able to go to the second, third, fourth, caregiver. You just might have that one, and then to follow up on that, how then do we manage bias and stereotypes that we encounter, in the case where you can't go changing your doctors like you're changing an outfit. If you have just that one and you're stuck with that one or that team, how then do you ensure that you get the best care for yourself, regardless of stereotypes or bearing in mind stereotypes and biases that they might have? Anybody want to take that on?
I can say something to that.
Okay.
I think it depends on the level of bias. If there's so much bias that I begin to distrust the healthcare professional, there's no way that I will advise anyone to stay there because you might actually be harmed. I used to be a patient. I thank God that He has delivered me from that situation, but I used to be a frequent patient with different doctors. And I remember one Indian doctor practice that I was at. I think they actually caused me a lot of problems because he didn't send me. It was when I was pregnant with my daughter, or before then. That anyway, they didn't tell me what I was supposed to do. And I actually was the one forcing and saying I needed to see a specialist before. It was an HMO at the time, and he had to give permission for me to see someone else. And he wasn't giving the permission. He was telling me I was okay, there was no problem and all that, until he finally gave me, which was actually too late by the time he gave me, and then other complications developed. So when that kind of situation happens, you cannot remain with that doctor. And I also remember another OBGYN lady that I had. It was a Caucasian woman, and I could see how she was. She was really very snappy. She really wasn't paying attention. She was suggesting surgery and other kind of thing. When I got to another woman, another white woman, but very, very kind, regardless of the color of her skin, I already saw that she was really, really very kind. In fact, when she left her practice to go take care of her parents. All the patients were writing all sorts of things, just crying like this woman. So, she's a white lady, but a compassionate person. And she completely went against what the former person said. So if I stayed with that person, then I might have had unnecessary surgery and all that kind of thing. So if it's to the level that the bias or the non-attention or the negligence or whatever of the doctor is there, you will have to find another doctor. And thankfully, unless you live in a very, very small town where there's only one doctor, usually there are options. But I understand that we don't need to leave at the first instance. It might be that we just need to be bold. I think what we can take from here, sometimes we can help our doctors. There was also a time that I was on a blood pressure medication and I was having side effects. I was having swelling. And then they wanted to add Lasix to reduce the swelling. And I told the doctor, well, if this blood pressure medication is causing swelling, it was Procardia, why don't I just go on another blood pressure medication? I'm aware that there are so many medications for blood. So I was actually the one that advised the doctor, instead of adding Lasix to take care of a side effect, why don't we go to another medication entirely? And we went to another medication entirely, and there was no swelling. So sometimes we just need to be proactive. We need to be bold to speak to our doctors, to tell them what's going on. But if it comes to the time when this is really a bad doctor, we need to run. Thank you.
Thank
I
you.
want to
Thank you
say
so much.
something.
Yes, ma'am.
I don't want it to be that at the end of this forum that it was stated that I said all Caucasian doctors are bad. I never said that.
No.
So I do want to correct if that notion came across in the slightest, notion, thought process. That's not what I'm talking to. But unfortunately, as an obstetrician and gynecologist, I have seen way too many things that when I said I made the statement that if it's not going well, don't even wait for the visit to be finished. Um, in gynecology, once you take out a uterus or an organ, you can't put it back. Unlike a blood pressure medication that you can, correct it, like she aptly stated about, can you switch me to something? I have seen instances of 22-year-old patients having a hysterectomy because of chronic pain, and the surgeon deemed it necessary. First of all, when you look anywhere, ACOG, even if they have cancer, conservative management is first line. If they fail conservative management, then of course, proceed with definitive surgical intervention. The surgeon, prescribed, surgery, and unfortunate poor girl, goes through surgery, and somehow hears about my name and comes to me, and by now she's having complications that the surgeon, who did the surgery was like, oh, it's already out, it's normal to have those symptoms. And so, of course, for me now is, first of all, at 22, why? And if so, why didn't you think about XYZ? Oh, no, I was told this is the only option. This is the only treatment option. And now that you have this complication, we can't put the uterus back. I can't reverse scar tissues. And of course, the complications you're facing now, we can manage them, but you're going to live with them for the rest of your life. That is just one instance. So for me, this is what I tell my patients. Their right to get a second opinion is their God-given right. I tell them that, yes, you heard it from me. I said, if you hear something from me that sounds outlandish or, this doesn't sound right, I said, I give you permission. It does not hurt my feeling to go get a second opinion, because I know that I would never prescribe something that's outlandish. I answer to God, not to my patients. So when they have to go through things that could detrimentally affect them for the rest of their life, I do recommend second opinion. So if it sounds uncomfortable from the get-go, because when it comes to a woman's infertility, time is of essence. I have had patients, 48, 59, 50-year-old, who were in the hands of a physician for 10, 15 years, that if they had gotten to somebody else, not necessarily me, sooner, maybe they could have had one or two children. But being told, oh, Black people have fibroids, it's okay. You're bleeding, it's okay. And now they're 48 and they have a huge submucosal fibroid tumor that, of course, I do my best to resect it, but then you scar that endometrium, and you refer them to infertility, and the infertility doctor is asking you, why are you sending this patient this late, Joy? And you're like, wait a minute, this patient just got to me, a month ago or so, a few weeks ago, and I'm just speeding them to you to see what you can do. Because by then, their fecundity rate has dropped. Their chances to get pregnant has dropped significantly after 35. So that's what I mean by, get second opinion. So my specialty, and I know this is a generalist thing, for my specialty, a second opinion is very highly recommended if it's outlandish. For other specialties, of course, they could, wait and see how it plays out. But for me, when time is of essence, Sister Tanuke just talked about a case of refer to MFM. That is not something I play with. I want to refer that patient as soon as possible. You have risk factors. Let me get that, co-management going, because I need a good outcome. I need the best optimal outcome for you and the baby. I don't want to mess the baby up and I don't want to mess a mom up. So for me, yes, I stand by what I said before. It's not about playing God. It's about go get a second opinion and leave as soon as you feel uncomfortable because it doesn't sound right.
Mhm. Very, very spot on, Dr. Joy. Very, very. And thank you for the passion. Even just from the way you're talking, it can be felt that you do love the work you do and you are taking it as a ministry, as a calling. So thank you on behalf of all the babies and the mothers that you work with. And of course, thank you to every doctor that's here and that's pouring your heart into the work you do. We can't thank you enough, especially for the care that you give. A question that, also then comes to mind is, before we go to the question, I'd like to read a comment here by, I believe this is Miss Abby. I'm not sure if it's Miss or Mr. Pardon me. I tell patients that they are the CEOs of their health and they have to help the doctors manage their health. On the other hand, we need to bring patient education back to the table as a priority. Most of the time, you hear patients saying, nobody ever told me that. Information is power, and it allows patients to take ownership of their health. So that segues us into, we've talked about other people. Now let's talk about ourselves. What practices, so bearing in mind now we're talking about patient education. In fact, let's talk about that. How do we ensure that patients are receiving the education that they need and the empowerment that they need to be better advocates for their care, especially from a preventive action standpoint? Dr. Finn, you want to take that up?
How do we, as the doctors and healthcare workers, ensure that they're receiving their information? So a lot of offices have really creative ways of doing that, sending people reminders when they're due for their annual exam. And then while they're there, we have a lot of educational material, like in my office. When we when people come in for their physical, they can, while they're waiting for us, they can watch a video. They can, read pamphlets, those type of things are really helpful while waiting in the waiting room. Nowadays, TikTok, although I don't recommend it, people are reading and listening to TikTok. They're listening to Dr. Google. So I always say, come in. I love it when my patients come in with written down questions that they have. And I'm like, let's go through each one. Whatever we don't get through this time, we'll talk about next time. So again, going back to being the biggest advocate of your health, just asking those questions and not leaving until your questions are answered. And then if they're not answered, that's your clue that you should find someone else. So again, we're not saying to give up on the first person or give up easily, but you'll know when when a provider tells you like, absolutely not, we're not doing this, and there's no question. Well, then, just an example, like if you feel a breast mass and you really want to get imaging for it, no one should say, no, I can't order that. We can say insurance may not cover this, but we shouldn't say we're not going to order that. So if they literally say they're not going to order it, and you know your body best and you feel like something needs to be ordered, then go to someone who's going to order it for you. So that type of thing. Yeah.
Thank you. Thank you, Mrs. Hawley.
Yeah, I wanted to say, regarding people or doctors not answering or asking you to do something else. My husband had to go to see a maybe nephrotic surgeon or something because a little less than 2 years ago, February of 2024, he was told that there was something on his liver. And so we went to this surgeon and he told my husband that he needed to have surgery to have that removed. And my husband asked, what are the other options if I don't want to do surgery? And he said, well, I've never, how did he even say it? That I've never presented another opportunity, as if, no patient has ever asked me to do something else or have never had, there's no other way for me or something to that effect. And my husband and I were there and we were all thinking the same thing. When we got out, I was like, this is zero for this guy. I mean, yes, you are a surgeon, I understand that. But even as a surgeon, if someone, and is another doctor that's actually talking to you, if they say, is there any other thing that we can actually do? And you said, and he just said it like, is either surgery or nothing else. So we already know that even if it's going to be surgery, it's not going to be this guy. And so because of that, we still haven't done anything. And I think the last time we checked, it was actually, whatever it was actually going down. So I think such a thing, I don't know whether to call it arrogance or something else or not caring, that would be a signal to look for someone else, in my opinion.
Thank you, ma'am. I think it's an interesting point you bring up about copy and paste kind of model where you present with this is usually what happens, and this is probably what is going to apply to you also to patients B, C, D as they come along. But thank you, thank you for sharing that. So I still like the idea of talking about patient education. And yes, we know that there are various ways that information is being shared this way. We know also, Dr. Finya talked about Professor Google. Dr. Google has good information and bad information, but I would rather we have all the information, good and bad, and then you go to your doctor and your doctor can help you filter and say, this is, just toss this out. And this we can work with, just like you said, go to your doctor with a list of questions, no matter how silly they might appear. It's your health. So go with your silly questions and let your doctor confirm if they are silly or if they actually are tangible questions. So let's come to our everyday living.
I want to say something.
Yes, ma'am. Go ahead, ma'am, please.
Dr. Fee mentioned Dr. Google as one of the sources. I am one of those doctors that have a visceral reaction to Dr. Google because of the fact that I feel that Dr. Google kills patients even before they start dying.
Yes.
Because of all the erroneous and sometimes good information that is misapplied. So I want you all to remember, and I think I'm going to type it on here. I want you all to remember Mayo Clinic.
Mm-hmm.
Now, Mayo Clinic is a website that, as physician, we got fatigued with all the wrong information, and it takes me a longer time to talk my patient off the ledge from Dr. Google than it takes to actually perform the visit. And I'm talking about infertility patients are typically the hardest patients and chronic pelvic patients for gynecologists. And when they come with Dr. Google, I know I'm sunk because they are so entrenched in the thought process that they have read in there that for me to convince them that that is not going to happen to them, it's almost like, wow, you know. So I hate Dr. Google with such a visceral reaction that I tell patients, if you want to be my friend and you want us to get along, don't mention Dr. Google. I said, I'm going to give you another website, Mayo Clinic. Any question they can fathom or think of going there because it is a reputable website that's been put together by physicians of all specialties that any question they can ask. And I know when they get information from Mayo Clinic, it is a question or information that I can trust, and they're not as panicked. It's like, okay, this is what you got. Let's talk about it. I actually like a well-informed patient. Yes, Mayo Clinic. I saw the Mayo Clinic. Typing Mayo Clinic and asking a question. A well-informed patient is the best patient, and an, an abnormally or misinformed patient is the worst patient. Dr. Fee and Dr. Alalaba knows what I'm talking about. A misinformed patient is a nightmare, you know, because there's nothing you're going to tell them that will take out that entrenched thought process in their mind. But if they're well informed, I can actually, you know, you can go along that journey and feel safe because almost like, you know, I'm being running a suicide clinic now because you're trying to kill yourself and I want to stop you from killing yourself. So I hate Dr. Google. And I don't know if the word hate is allowed here, but I just want it to be noted. Mayo Clinic, you know, is the preferred website, please.
We vote Mayo Clinic. We detest Dr. Google. Okay, thank you so much for um, setting us on the right path, ma'am. Thank you very much. Yeah, that was very needed for us to know because truth is some of us are curious. We'll still go to Google to say, what is this? At least I know for me personally, when I put in stuff, I actually skip the portion, the AI part, and go down. So I do look for Mayo and Cleveland, and I just go down or even read a paper on something. So that's the way I do. But I know not everybody is that particular. So you see the first thing and you just jump on that. So thank you for bringing on Mayo Clinic. Um, so coming to daily practices, what are some things that we do every day, or what are practices that we overlook that are important when we think about proactive care? So if does that question come around, does that question come across, you know, understandably, let's say Dr. Joy. Dr. Joy, you want to continue?
Yes, one of the most important things that we overlook is our diet.
Mhm.
Um, in the Bible, and I'm hoping that those who are here, you know, our Bible believing people, and if they're not, it's not an affront or offense to you. In the Bible, God told his people that, you know, if they eat like this, he will not put the diseases that the Egyptians had in them. You know, weight loss, is 80% your diet and 20% exercise. And one of the underutilized tool in medicine that I've personally found is fasting, intermittent fasting or fasting. The Bible tells us man shall not live by bread alone, but by every word that proceeds from the mouth of God. It is true. We overeat. And when you live in a country of affluence like the United States or any other Western world, the opportunity to, or the, I wouldn't even say opportunity, the the choices to overeat are so overwhelming. You go to grocery store, you have 1,001 choices. But when you live in the poorer countries where you don't have those choices, it becomes easier to fast, you know, not by choice, but unfortunately by circumstance. If we allow our diet to be as minimal, but full of the micro and macronutrients as much as possible, I believe that we've even done more than half of the job. And when we talk about exercise, people talk about getting regular exercise. Meaningful exercise, is neglected. Meaningful exercise is something that a lot of people don't pay attention to. And for us, meaningful exercise is what you're doing on a consistent basis that increasing your fluidity index. What that index is basically is how frequently your blood is running back and flowing back and forth. The higher fluidity index, because you're moving constantly, you're removing free radicals and allowing antioxidants to come in. A sedentary lifestyle, even for a skinny patient, is at increased risk for dying compared to someone who has a BMI of 30 but moves on a regular basis. And I don't know if people on this platform had ability to see Dr. John Schaffenberg on Amazing Facts, and he talked about how they were shocked to see in the studies they did that, patients who were considered obese that moved regularly, 3 or 4 times a week, of course, started at 30 minutes going up to 60 minutes, had a lower death index, risk compared to a skinny patient who doesn't move. But diet, and often people are like, well, how do I eat? So I have this thing I do in my office when they come in, as part of their annual exam. I draw out a plate, a round plate. You divide your plate in half. And then that half, I'm going to mimic that drawing for you. I flunked out of fine arts class for a reason. So do not laugh at my drawing, but I'm going to put it up so that you can see what I'm talking about. So here is your plate divided in half. I don't know if you can see this, if it's blurred out. That is divided in half. Can you see it?
No, we
No?
can't.
Okay.
No, but
So imagine a round plate divided in half. That one half is your rainbows, your R, all the wonderful colors in the produce section that God has put in the produce section. That is one half of your plate. The other half of your plate you divide in half. So your fish and chicken. If you notice, I didn't put, red meat, goat meat, and other because now with the recent studies, eating red meat has been linked to smoking 2 packs a day or more because of increased risk for chronic disease, heart disease, and cancer. And then the other half that was divided in half is your legumes, your sprouted grains, your whole grains, your sweet potato, pound for pound, your sweet potato is your most nutritious food in your produce section. If this is our plate on a regular basis, and then, if nobody heard me say white bread, white rice, white flour, brown rice is part of that, whole grains and stuff. If we're eating like this on a regular basis, or, maybe not all the time, but more than, half of the time, you are eating both your micro and macronutrients. The body has been designed by a wonderful, maker. We're fearfully and wonderful made. If we feed the body what it needs, and eating right, exercise, moving, um, hundreds of years ago, they didn't have treadmills, they didn't have gyms, but they were always moving. They were working hard. In Africa, growing up, I don't remember ever stepping foot in the gym, but you walked from the motor station to the next bus stop, and our portions were smaller. And we didn't have the abundance of weight or difficulty losing weight that we have. But that's what meaningful exercise comes in. And then our diet was, proportionately controlled that we ate what we needed. We overeat. And hence, if we're eating, to eat, we're going to die. And we eat to live, but we're not living to eat. That's why I talk about intermittent fasting and fasting, taking time to give the digestion a rest. Growing up, I don't remember us eating and snacking in between meals. I really don't. And if I'm forgetting it, God forgive me. But here we eat breakfast, we're snacking, we eat lunch, we're snacking, we're eating dinner. There is no rest for the digestive system. We burden it. Hence, when they talk about gut flora, our gut flora is poor. But when we actually allow the body to rest, fasting does brilliant things to the body. The brain, every cell in your body gets a break and it actually functions well. And when we're moving, I tell people, you don't have to own a gym membership, but if you do, by all means, honor it so you're not wasting the money. Meaningful activity is, when you're parking your car at the grocery store, park at the very end, of course, during the daytime, not at nighttime, so you don't get mugged. Take the stairs, not the elevator. Carry your luggage, push your cart. Those are all things. Don't use remote control. A vacuum, instead of an iRobot or whatever that thing is that, vacuums these days. Those are things that, we do at home that can help improve meaningful activity. And it's amazing when we do that on a regular basis, you're getting the body to do what the designer has made it to do.
thank you. There's a question here that says, from what time to what time do you suggest intermittent fasting?
So it depends on how likely you're to succeed. Now, if you're somebody that eating breakfast, now let me say this, data tells us that breakfast is the most important meal of the day. That is true. But if you eat breakfast and you intend to fast and you eat lunch and you find that by evening time, you're so hungry and angry that your family members don't recognize you, they think you're demon possessed, then change your fasting time. Try to do fasting from lunchtime, noon to 6 p.m. That way, your body is able to function because you're more likely to succeed. I tell people try intermittent fasting when you're more likely to succeed. There was a data, and I don't remember exactly the name. It was one of my dinner with the doctors slides that has it, and I'm trying to recall it. It talked about intermittent fasting was the weight loss was optimal with those who ate breakfast and cut off eating by either 2 p.m. or 4 p.m., depending on when they ate breakfast. But they also saw that those who couldn't maintain it were worse off because they were getting hungry and then they'll end up eating again at 8 p.m. or 9 p.m. But those who did by lunchtime, which is 12 noon or 1 p.m., and ate their last meal, if possible, I say if possible, by 6 or 7 p.m. That means you're going to bed at 9 p.m. You want to eat before 3 hours before you go to bed, or 7 p.m. That way you're going to bed latest at 10 o'clock. They had success too because of the fact that they stuck to it. If you're doing something consistently and you maintain it, you're likely to succeed than something you're doing haphazardly. So there is no definitive time per se that is best, but it's what is more likely to be consistent that you're going to be successful at so that you don't fail. Because people who claim they're intermittent fasting, they'll eat that during that window of 8 hours and then they're snacking again. You've fallen out. Your body does not see intermittent fasting. It's 8 hours of eating, 16 hours of no fast. People who are stricter will do 4 hours window of eating, which is a little bit too strict, and 20 hours of no fasting. Those patients, studies show that those patients tend to fail. So I tell my patients, practice 8 hours of eating. Within those 8 hours, eat your, and do not snack in between. Water, put ginger, put lemon, put orange, whatever it is to spice the water. Do tea, chamomile tea, ginger tea, raspberry tea. It gives your gut the feeling of being full. And then you eat two meals a day and a good meal, good size meal, meaning that you're eating like the plate I was describing to you. You're getting your micro and macronutrients. Those patients lose weight. I've seen it in my office, and they don't even have to get the new craze of the injections because they are eating the way God designed us. So you're giving the body a break. And then adding meaningful exercise. If they have a gym membership, I tell them honor it. If not, go out in nature. God has put sunlight, fresh air. Nature beckons us, come, let me heal you. Get out and get some walk and, go for a walk. At least go between the prime time to get that vitamin D, which helps stimulate metabolism as well. If they're doing all these things and practicing moderation, trust in God, and all the positive things that we've been asked to do, I tell you, we will have less diseases. Now, we do our best, but we know we live in a world where the enemy is the author of disease. He wants to hurt God's children. And if you get disease, it's not because you didn't do it right, but at least you've done your best. And that's what I tell patients. This is not a guarantee that you're going to live 100 years or more, but at least you've done your best. And if you get disease, you're more likely to survive it. COVID showed us that those who were, poor, that had poor health or ill health, tended to die more from COVID than those who are healthier. When we had the COVID pandemic. So even if you get sick, you're more likely to, recover and overcome. But do your best and let God do the rest for you.
Thank you so much, Dr. Joy. In fact, I feel we're going to have a part 2 to this session because we are sharing information that is just a lot to unpack, and there's still a lot more to go, but our event usually, by now we should be wrapping up. So I crave our indulgence for a few more minutes, about, let's say, 10 to 15 more minutes, just so we can touch on some other important questions that we have here. And then we would work on a part 2 to this, where we actually come down to specific proactive care from a woman's standpoint or from a man's standpoint or from a pediatric standpoint. I think there are still a lot of things that we need to unpack when it comes to gender specific or age specific care. To the Fawales, please go ahead.
I have a question, but I also see that there was a question that we put at first that you probably didn't see.
She saw it.
Okay, about infertility among couples. But the question that I had now is they talk about sometimes, because I'm able to do intermittent fasting, but sometimes I'm not sure. I've heard that, and I might not be saying this in the scientific way. I've heard that sometimes if you don't eat, then your fat, then you begin to burn your fat, which then, which is negative or something. I don't know if you understand what I'm saying. So even though I'm able to do without eating, I'm now wondering, well, I don't want my fat to be burned, or I don't, am I saying it correctly?
No, you want your fat to be burned too. That's
I
what.
think what you're asking is does your body think you're starving, so then it retains fat or holds on to the fat?
Exactly. That's exactly what I'm saying. So how do you avoid that if you are doing intermittent fasting? How are you sure that your body doesn't see it as you're starving and then begins to retain? Yeah, exactly. Thank you.
So, so studies have shown that if you're doing intermittent fasting, you're doing 8, 16, or extreme 4, eating 4 and 20, you're actually not going to get into that starvation mode. There are people who do the extreme fasting of, 48 hours, 72 hours. And even at that, the chances of really, really starving is not as high as is made out to be. Um, Autophagy, which is a whole different, topic, is something that we're still studying, but it's so interesting that, when people fast a little bit longer than they think they can handle, autophagy begins to happen. It's almost like your body is saying, I'm going to clean up all those extra things that you don't need, and now if you're going 40 days, I believe that it takes the Holy Spirit, like Moses and Jesus, 40 days without food and water. That's not what we're talking about. But regularly fasting, your body knows this is your time to eat. You're not going to go into, starvation. Your body says, Sister Tinuka eats from, 8 a.m. to 2 p.m. or 8 a.m. to whatever time every day. Once in a while you're on a trip, you miss a flight or something, she doesn't eat. Your body doesn't say, oh, we're going to screw up. It's, consistently messing up. The righteous falls 10 times, and gets, 1,000, gets up 1,000 times. It's consistently messing up that your body says, okay, this is no longer intermittent fasting. But you have a trip or something comes up, but you get back to doing, your body says, yep, I remember this, the memory cells that your body has created. So the fear of starvation is not actually real, is more perceived, is what I'm trying to say.
Thank you. Dr.
You're
Finn, do you
welcome.
have something to add to that? Or we could just,
No, I was gonna say the same thing, like the 16 and 8, which is the one that I usually recommend because just like you said, it's the one that most people should be able to do. Does not cause that to happen. So
Thank you. Thank you so much for the wealth of knowledge that you are sharing and that we are enjoying from you. So I am trying very, very much here to manage the time, and I don't want to keep us longer than we should. But permit me to ask about 3 more questions, and then we can just give, short responses to this. So to empower ourselves, so that today's discussion event wasn't just about talking, but for us to also walk away with actionable things. What are top 3 preventive checks that every adult or every individual need to prioritize? And when should these checks be done? Dr. Finn, would you take that, please?
yeah, I think just so that I know you said that we're gonna have to have a part 2 about what women need, what men need, but I don't want us to go through this session without talking about one big cancer, or I guess the 2 top cancers that are highly preventable in this day and age, which is colon cancer. I want to say number 1 and talk about that. So when we're talking about top screenings for adults, it's going to be those cancer screenings, because again, we have tools now that can catch them early or even catch them before their cancer. For example, for colon cancer, which it used to be 50, now it's 45 to start getting screened at 45. A number of patients are getting it a lot earlier. Again, we think it has to do with the diet, and different environmental factors. So because people are now getting it earlier, we want to start screening early. And the way to screen is with a colonoscopy, because with a colonoscopy, you can not only screen for the cancer, but you can also prevent it. So if there is a polyp or something that is seen in the colon, you can take a sample, biopsy it, and if it's cancer, you know what you need to do to, or if it's precancerous, you know what you need to do to prevent actually getting cancer. So that's a big one. The other one is mammogram for our ladies. Again, breast cancer, also very common. At least 1 in 8 women, and I think we have more than 8 women here on the call, will get breast cancer in their lifetime. And so because of that, again, we have the screening that if it's caught early, it's very treatable. It's been a very rare case where I've seen a patient that is, stage 4. Actually can't think of, a patient that has been stage 4 that got the screening at the recommended age. Again, it's patients that haven't been seen by anyone in 20, 30 years. And so they never got the screen that could have prevented them now being untreatable, which is, what it means to be stage 4. So yeah, those would be the top screenings, is the cancer screenings, and then vaccines. There's a lot of talk right now about vaccines. And so again, would be remiss if we're having a conversation like this, and particularly among, Black people, there is a fear of vaccines because of different things that have happened in the past with testing and things being taken advantage of. But the overwhelming research around vaccines is that they prevent these diseases. We no longer see certain diseases when we were all getting vaccinated, sorry. And now that people are, not wanting to get certain vaccines, we now see things coming back, measles, polio, things that we didn't have to deal with before. So yeah, those would be the top things that we need to make sure we're staying on top of.
Thank you so very much. I did have that thought about vaccines also, so I'm glad that you talked about it. And yes, thank you for also touching on things that we mustn't, we mustn't leave here without talking about. So thank you. Dr. Joy, what are your thoughts on this milestone screenings that must be done? And either you can speak either for, women's care or even just general, individual care.
So I'm going to speak on mostly women's care because my colleague has already talked about, general care, which involves both male and female. I'm going to touch on the colon cancer. A lot of people have a fear of colonoscopy because they understand it's an outpatient endoscopy procedure. I've never been put to sleep. I'm afraid to put to sleep, or I don't want to drink that nasty drink. So we have an option of Cologuard. Cologuard, yes, is not as specific as colonoscopy. What do I mean by that? A specific test tells you you don't have this disease and you're good. A sensitive test will pick up a disease. So, Cologuard is a good sensitive test. And yes, if they detect any blood in your stool, then they want you to do what we call the diagnostic test, which is a specific test, colonoscopy. There are many women who have refused for me. When I say we're scheduling you for colonoscopy, absolutely not, Dr. White. I'm not going to do that. Never going to do that. Then I always will meet them halfway. What about a Cologuard? And I was explaining to them what it is because, amazingly, they haven't heard about it. And I tell them if it's positive, meaning that you have blood in your stool, we have to do a colonoscopy. Okay, then I'll do it. They agree. That's how I'm always trying to meet them halfway if possible so that to get them to do the screening. And that's the other part. I was just picking back on my colleague. And then she mentioned the mammogram. The complaints for me as a gynecologist is I don't want my breast to be squished. So I always make the joke that a man designed mammogram because no woman would design anything that would squeeze a woman's breast. If a woman designed mammogram, it will come with pom-poms and red pink and it'll be soft. But we need, compression to be able to see the breast tissue, especially in patients who have dense breast tissue. The danger for a lot of people who we're seeing now that they got their mammogram. And yes, mammogram has a 90%, sensitivity and 10% false negative, meaning that you get a report card, oh, your mammogram is Barrett's too, which means it's normal, and they're fine. But they're doing their monthly breast exam and they feel a lump, which unfortunately many women will normalize what's abnormal. They're like, well, I had a normal mammogram, so this lump, maybe I don't even know what I'm feeling. And they tell me I have dense breasts. We now know, that, for us, that if a woman has dense breasts, a simple screening mammogram is not sufficient. A diagnostic mammogram or even an MRI is more helpful to be able to detect a mass that a dense breast. And what is a dense breast? I use this analogy for my patients. A dense breast is a bag of beans versus a bag of rice flour. We that eat fufu, we know what rice flour is flat. Beans is more, dense. You feel those little, if you grab a bag of beans, you feel those little, nuts in it. That's what a dense breast feels on exam. So a patient is like, well, it's full of nuts. I don't know. And I always tell them, no, you're not. Because even though you have dense breasts, there's going to be subtle changes. The skin looks like the skin of an orange, which is what we call port orange. That is not normal. Your nipple, instead of being an outer nipple, is an inverted nipple. That is not normal. All of a sudden, you have red streaks. And because we're dark skinned, we don't see those capillaries that are all over our breasts. The Caucasian patients, you see better. But I tell them, pay attention, look in front of the mirror. I always try to teach every patient that comes in for the annual exam or even any exam how to do a breast exam. Stand in front of the mirror during the week of your menstrual cycle, hands on a hip, hands raised up. So you're putting the breast on tension. You're looking at the breast in front of the mirror, not looking down. You're looking for changes. Pay attention to any subtle change. And then when you get in the shower, not on your bed, in the shower, because moist hands and moist skin, warm water and soap. And you want to start right at the clavicle is the border of the anterior border of the breast tissue. You want to walk yourself up and down. The opposite hand palpates. And when you get to the armpit, you want to swing down and check the whole entire breast because lymph nodes and mass could hide there. And repeat once a month. I tell them if you know your breasts, you're likely, that's why we call it self-breast awareness. I tell them I'm not trying to make you a breast surgeon, but I want you to be aware. If you're aware of your environment, you're going to be like, oh, they put up a new sign. They're building a new house. That's how finely attuned you are to your breast that even after that screening mammogram that has a 90% sensitivity, you can call your doctor and say, I felt something. And yes, Dr. Feeney mentioned earlier on that some patients will have a breast mass and some doctors will tell them, no, it's in your head. You don't, but, or you're too young. The youngest patient I diagnosed with invasive metastatic breast cancer is 26. Right now, I have a 31-year-old that has stage 4 metastatic breast cancer. 31. She came with a breast lump. She had it 6 months ago and was told, don't worry, it's probably your menstruation, and she insisted and got a screening mammogram and it was read as 3B. Now I go back and I'm reviewing a mammogram. I'm reviewing the images. I'm not a radiologist, but of course, Dr. Fee knows and Dr. Alaba knows. We go through radiology, and for me, through education and watching, the imaging studies, I want to be able to tell my patient this looks abnormal. I don't trust this reading. Let's get an ultrasound. You can clearly see there was a mass that was missed. That is that part that as doctors we're not perfect. So that was in December. So she comes to me, last month, which is, September, and I'm palpating a solid mass. So of course I ordered diagnostic. She's 31 and she gets a, biopsy. It's read as a 4S. She gets a biopsy. It is poorly differentiated. And then she has positive lymph nodes. She gets a PET scan. It's in her spine, in her hips, in her lungs. It's not in her brain, thank God. It's not in her neck. It's everywhere. 31. So basically, yes, age of screening is 40, but if there's any suspicion, do not hesitate. If the doctor tells you you're too young to get a screening, run with your heels touching your head to another doctor who will get that test for you. And then I do want to touch on cervical cancer screening. A lot of young people don't go get their cervical cancer screening because they don't think, that they need it. They think are not at risk. But unfortunately for them, they may have lived their life right, but their partner may have had mistakes or not even know they had mistakes and been exposed to HPV. Human papillomavirus is the most commonly sexually transmitted virus. Hence, a woman is at risk. And why is a woman at risk compared to male? Why don't we see penile cancer? It's because a woman has an unhas cervix transformation zone. That is why when a young girl starts having what we call early coitus sex early, she's at greatest risk. Because when she's growing up, her transformation zone, once she hits puberty, her transformation zone is actively dividing, and that virus will attach to that transmission zone and will attach to a gene called the E6 oncogene and will multiply, just rapidly dividing. That is why the vaccine initially was put out for age 9 through 26. Now, when we saw that in our counterparts in Europe, have almost eradicated cervical cancer by extending the vaccine age, it has now been extended to 45. So every time I see a young patient that's less than 45 and they have abnormal pap smear, I tell them, go get this vaccine. Gardasil 9, get the vaccine. Dr. Fee already mentioned it. It's helpful. But unfortunately, sisters do not come often because they're afraid that vaccine, because I don't blame them. When you look at the Tuskegee program and other things, we've been dealt bad. but they stay away. And then that's why you will see cervical cancer more in younger, Black women than in Caucasian because they go get their vaccine. If you're less than 45 and you're sexually active, married or not, please get the vaccine because it's been extended because we saw the efficacy of it. The studies were done in Europe and then we did our studies here and we found it was helpful. So those are the two, screening things, get your mammogram, get your pap smear as a woman, get colonoscopy. And if you're planning on starting a family, please get preconception counseling. It makes a difference what you learn, what you can start doing, how to eat healthy, when to come in when you're pregnant, signs of ectopic pregnancy or miscarriage, so that it can be appropriately dealt with, and that way you can get a good outcome in pregnancy. I'm always afraid when patients who have health issues, blood pressure, diabetes, enter into pregnancy blindly. Having diabetes does not sentence you to having a dead fetus or bad outcome or high blood pressure. We can still mitigate those risk factors for an optimal outcome. Yes, we can because we do it all the time till tomorrow. So those are the screening things that, I encourage patients to consider, those big three. And I don't know if I have time because the question that the Fowler's put out about infertility, I don't remember if I saw it, or if you saw it. And I know we're running late. We could table it for another time, to discuss, but I don't want them to feel like I'm dismissing answering their questions if it was directed to me, because those are my people. I don't want to dismiss their questions. Okay?
Yes, thank you. Thank you so much. I plead with you, the panelists, that we move this question to the part two of this conversation, just because I want to honor everybody's time here, bearing in mind also some people are calling from regions that are already at night, so that they can go to bed. And yes, we would, but just to read out the question, Dr. Joy. I did see the question and says, I think many couples experience delay in conception lately now than before. Is there anything we can proactively do to address this? So that would be I've already copied it out and added it to the pool of questions that we'll be discussing in the part two. And the part two is actually going to be tagged I think it's called Health and Anatomy or something like that, because we already have that stacked up. So that is going to be the part two for this. And hopefully in the near future, we just have to get through this holiday season. There are some topics that still apply to this season. And then probably in the first quarter of next year, God willing, we will touch on the part two for this. But I do thank everybody for being very patient and for being here. If we imagine if we just gathered if we gathered here and was just myself and the panelists talking, we'll get tired after a while. But having you join us here helps us to know that, and you're staying all through, helps us to know that what we are talking about is important and you can relate to this topic. So thank you. And like we had said in the beginning or at the beginning of this event today, if you have topics that you want us to touch on, to talk about, if you have concerns that you would like us to bring in experts on and talk about. So it will be nice to hear from you. I am going to share my screen that helps us to see the ways that we can connect. And we can connect by email. And our email is, you see it up here, it's dg@embracedg.org. And our website is www.embracedg.org. And you can also connect with us via social media. And we do pull out the audio from these discussion events because we know a number of people would like to listen in and they just are not able to join us today. So if there are episodes you have missed and you would want to catch up on those, we pull everything out and publish it as a podcast. So you can listen on our podcast channel. That's Doing Good Impact Podcast. That's what it's called, Doing Good Impact. And if you believe what we're doing here is important and is good, we also invite you to support us. And you can support us in, two various ways. You can support us, like I said, by listening to the podcast channel and also sharing it so other people can listen. That is also what you can do in terms of health awareness and health creation. And then we also you can sponsor an event. So you can like I said, we do this event here and then we pull out the audio, we publish that on the podcast, we try to disseminate in other ways. So these are things that you can do to support the work we do here. And before I come to the panelists for one sentence or a very quick final thought, I'd like to put that the next event is going to be the fourth Sunday in November. So the Sunday before Thanksgiving, and that's November 23rd. We will be having a very juicy discussion also, the healthy kitchen. So before we start cooking and doing all the holiday activities, let's know how we can lean into our kitchen to help us with our journey to optimal health. And that said, I bring it back to our panelists. Thank you so much for being here. Thank you for the wealth of information that you have shared. I have personally gained a lot, and I believe I speak for everybody that we all have gained a lot also. But very, very quickly, in less than, if we can do it in 1 minute and less, that'd be good. Final thoughts, and I would start with Dr. Fain.
I just hope that everyone will be proactive about their health, meaning the things you do every day. We talked a lot about diet and exercise. The one thing we failed to mention was sleep. So that's a huge one. Everyone, it's recommended at least 7 to 9 hours a night is for the best health outcomes. But not only doing what you do at home, but also, seeking that care with someone you trust and never giving up until you find the right person for you.
Thank you. Very well said. Thank you. Dr. Joy.
So, in follow-up to my colleague, I'm hoping that the discussion we've had here today has enlightened many people that proactive means you take baton, you run, you begin the work. I use Creation Health as a way to initiate discussion with my patient. Creation is an acronym. The C stands for choices. It begins with healthy choices from the moment we wake up in the morning throughout the whole day. And the R in creation is for rest. That rest, we add, creation is an Advent health program. We believe in the weekly Sabbath rest, but my colleague already mentioned the sleep. And it's not just sleeping 7 to 9 hours, it's actually finding time to restore, rejuvenate, refresh. A lot of us don't know what vacation means. Vacation, the word vacation means leave your current problem and take a reprieve, take a rest. Jesus called his disciples away and said, come a while away and return so that it refreshes, restores you. And then, of course, the E in creation is environment. Wherever we are at any time in life, our environment is actually positively or negatively impacting us. And that environment includes in outdoors, go outdoors, fresh air, sunlight. If you garden, enjoy it. Indoors, bring in flowers, open the windows for fresh air, keep it nurturing so that it can continue to stimulate positive influence in your body. And A is that meaningful activity we've talked about, regular exercise. And T is trust in God. Because if we look healthy, we're size, whatever it is that's ideal for us, but we don't have trust in God. We're a glorified sinner, walking around. But when we trust God and submit our lives to Him, we actually are getting optimal health. And the I in creation is for that positive interpersonal relationship. If you're in an environment, a place where your little village and those who are around you are torturing you, or it's more stressful, it can actually be detrimental. Positive interpersonal relationship fosters good health and always outlook. I use the half glass, look at your glass as half full, not half empty. Because when you have that positive outlook, it's actually helpful. University of Florida completed a study, I believe it was about 2 or 3 years ago, that showed that patients who have a pessimistic negative outlook had increased risk for dementia, which was surprising to them. They followed these patients for several years, and they were shocked to see that the more negative and pessimistic their outcome was, that they had an increased risk for dementia. And then, of course, N is nutrition, which I've already talked about how to eat. Practice as much as we can, we fail, but we don't give up. It's like riding a bike, you fall, you get back on. And as we do these things, we trust God, for the rest, because we're doing our part. And I wish you all the best creation health and the optimal health.
Thank you. Thank you so much. I think that is a very wonderful way to end today's discussion event. I wish everybody wellness. I wish everybody a very wonderful week coming in, and I look forward to seeing you here next month. And also, I look forward to seeing our panelists when we have the part 2 of this to this discussion, because it's been a very lovely one, and I believe everybody shares the same sentiment that we would love to have you come back. So I hope that's a yes. All right, thank you so much, and that's a wrap for today. We can unmute and say hello to each other if we wish to.
Thank you for having me here. This is my first time here, and I'm very delighted to be part of this. And thank you, Kemi Olaolu, for the wonderful work you're doing. Truly, the Bible says a nation perishes for lack of knowledge. When you're empowering people, you're actually saving lives. So may God continue to hold you up. The Lord is your strength, and many lives will be positive impacted. So thank you for inviting me to be a panelist here.
Thank you. Thank you so much. Thank you. We look forward to experts like you to help with the work, and may God bless the work we all do. Amen. Amen. Thank you.
Thank you so much.
Thank you. Thank you. Thank you, Dr. Joy, very much for all the wealth of information. Thank you, Dr. Fifi. Thank you, everyone, for your contributions. It's great.
Thank you.
Thank
Thank you,
you.
Dr.
Good to see you.
PJ.
Thanks for your support
God.
always.
To God be the glory.
Thank you.
Bye.
Bye-bye.
Bye, everybody. To those in Nigeria, good night. To those in the UK,
night.
good night. If there's anybody in another zone, good night or good morning. And to everybody here, enjoy the rest of your day, and I wish you a very blessed week. Thank you. Thank you so much, everybody.
Bye.
Thank you.
All right, goodbye.
Goodbye.
Let me stop this.
Nice. Maybe it's some blog.